greet you in the awesome name of my Lord and Savior Jesus Christ. It's Dr. Ryan here. Hope you and your family are well. Thank you for joining me in this overview video. It's our third in the series, and we're going to be taking a closer look at clubbing. First up, let me just tell you a little joke. The other day my friend was telling me that marriage is much like a deck of cards. I said, what? Why? He said, well, initially it's all about hearts and diamonds. After a while, you'll settle for spade and a club. Okay, guys, let's dig in. This is our clinical case. A 53-year-old man is admitted with fever and right pleuritic chest pain for 5 days. Interesting. He has a history of alcohol dependence. On presentation, his temperature is a whopping 39.2 degrees Celsius, so he's pyrexial. He's tachycardic at 112 beats per minute. His blood pressure is 102/62 with a respiratory rate of 24 breaths per minute and an oxygen saturation in room air of 92%. Not too shabby. He has digital clubbing. Bear that in mind. He has absent breath sounds in the right lower chest with dullness to percussion and decreased vocal fremitus. Chest radiograph confirms a right lower lobe consolidation with an associated effusion, which is not free-flowing. Oh dear. Initial thoracocentesis demonstrates gross pus in the pleural space. Gram stain is positive for our beloved gram-positive cocci in pairs and in chains. A large bore intercostal chest drain, that's ICD, is placed. Now, which of the following treatments should also be recommended in this patient to improve resolution of his empyema? Is it immediate referral for decortication? Is it B, interpleural installation of alteplase? Or is it C, interpleural installation of alteplase and deoxyribonuclease DNase? Or is it D, just DNase? Or is it E, streptokinase? Interesting. Guys, let's start talking about clubbing. What is clubbing, really? Well, it is defined as a bulbous enlargement of the terminal phalanges of the fingers and toes with an increase in the soft tissue mass and curvature of the nails. How do you go about examining a patient for clubbing? Well, there's many things you can do. Firstly, you can just inspect the fingers and the toes to see whether gross clubbing is present or not. Sometimes clubbing is somewhat subtle, in which case you need to look carefully at the angle between the nail and its base at the level of the observer's eye. The normal angle is 160 degrees. Next, you can palpate and check for fluctuation of the nail bed. And we can also elicit or try to elicit what we call the Shamroth sign, where we place the corresponding opposite nails of both hands together. Interestingly, Dr. Shamroth was a South African doctor, which is amazing. Well done, right? And also, you want to look for convexity of the nails from side to side. And in the advanced stage, what you may actually see is drumstick or parrot beaking. Right? You also want to check for our beloved HPOA, which is hypertrophic pulmonary osteoarthropathy, by pressing the ends of the long bones and looking at the patient's face if they wince in pain. Here's some beautiful illustrations, courtesy of short cases in clinical medicine. God bless you guys. And here we can look at the fluctuation test, right? By pressing on the sides of the nails from side to side and test for fluctuation. Here's a Shamroth sign. Normally you can see a diamond shape if you place the two fingers adjacent to each other, but in clubbing, this angle is obliterated. Here we can see gross clubbing, parrot beaking, and drumstick clubbing of all of the fingers. Remember, you also need to look at the toes. Don't neglect the toes, not toes now. Look at the toes. For clubbing, this is drumstick appearance, parrot beaking appearance, clubbing with cyanosis, which has a differential, which we will talk about. Alrighty. So what is an early sign of clubbing? It's basically softening of the nail bed with obliteration of the angle of the nail bed, as we have seen in those pictures. Now, what causes clubbing among the middle-aged to elderly population? Well, we can partition it into respiratory, cardiac, and others. Under respiratory, bronchial carcinoma, commonly the squamous cell type, all right? Then we talk about suppurative lung diseases, the likes of bronchiectasis, lung abscess, and empyema thoracis, as in our clinical case. Then, of course, there's diffuse parenchymal lung disease, which was previously called interstitial lung disease, but the nomenclature has changed. And, of course, very common in our clinical setting here in South Africa, pulmonary TB. TB. Not just any TB, it's advanced stage tuberculosis with resultant fibrosis. Cardiac causes include infective endocarditis, cyanotic congenital heart disease. Others include cirrhosis of the liver, primary biliary cholangitis, inflammatory bowel disease. Sometimes it can be familial. Okay, what causes clubbing among Kiddos, well, once again, respiratory culprits like suppressive lung disease, the likes of what we've mentioned before. Cystic fibrosis is another condition, right? Pulmonary TB again. Cardiac causes is cyanotic congenital heart disease, especially totality of fallow, which we covered in our previous video on cyanosis. Infective endocarditis. Others include chronic liver diseases, and must watch out for these genetic ones, like Wilson's disease and alpha-1 antitrypsin deficiency. Okay, so what important history should we take from a patient with clubbing? Very important is a family history, especially of any of those hereditary conditions that we described. Cystic fibrosis, alpha-1 antitrypsin, and of course, if there is clubbing in the parents as well. Respiratory symptoms such as cough and hemoptysis and chest pain and breathlessness, which makes us think of a respiratory cause for the clubbing. Cardiac history, especially alluding to cyanotic congenital heart disease, infective endocarditis, gastrointestinal symptoms like diarrhea, which points to inflammatory bowel disease, especially if it's bloody, history of liver disease as well. Alrighty, what's the term differential clubbing? What does that mean? Are we referring to calculus here with differentials? No. Differential clubbing just means clubbing in the toes but not in the fingers, or vice versa, where there's clubbing in the fingers but not in the toes. So causes of clubbing in the toes and not in the fingers, what are they? A patent ductal satidiosis with shunt reversal, which interestingly also gives you differential cyanosis. If you have an infected abdominal aortic aneurysm or coarctation of that abdominal aorta. What are the causes of clubbing in the fingers but not in the toes? Chronic obstruction of veins, which is phlebitis of the upper extremities, which is very common among the population that uses IV drugs. What are the causes of clubbing of a single finger, something we affectionately term unidigital clubbing? Well, it could be repetitive local trauma, which is by and large the commonest cause. Also chronic tophaceous gout, sarcoidosis, and if you injured your median nerve right there. What are the causes of clubbing with cyanosis? So diffuse parenchymal lung disease, cyanotic congenital heart disease, the likes of totality of fallow, Eisenmenger syndrome, where there's a reversal of that shunt causing right to left shunting in the heart, an admixture of venous and arterial blood, cystic fibrosis, as well as bilateral extensive bronchiectasis. Righto, pseudo-clubbing, what is this thing? Right, and what causes it? Well, pseudo-clubbing looks like clubbing, but there is no soft tissue proliferation or increased curvature of the nails. It is simply due to resorption of subperiosteal bone terminal phalanges. And the causes are systemic sclerosis and not hypermarket now, hyperthyroidism, yes. So how do we grade clubbing? Well, there's 4 grades. Grade 1 refers to softening of the nail bed with fluctuation. That's simply due to proliferation of cells at the nail base. Grade 2 refers to increased curvature of the nails, which eventually become convex, and the angle between the nail and its base is obliterated. You no longer see the shamrod sign, hey? Grade 3 is where there's increased pulp tissue resulting in drumstick or parrot beaking or both. And grade 4 is, of course, where you have hypertrophic pulmonary osteoarthropathy. The golden question everybody wants to know is, what are the mechanisms of clubbing? I mean, what really causes clubbing? Well, people say arterial hypoxemia. There's also some theories about humoral mediators that induce vasodilatation, the likes of bradykinin, prostaglandins, and 5-hydroxytryptamine. Others say neurogenic factors through vagal stimulation, and the proof of this is that patients who have clubbing and undergo vagotomy reverses the clubbing in such cases. But I think by and large, the most popular theory has to do with platelet-derived growth factor, our beloved PDGF, which is released from megakaryocytes and platelet emboli in the nail beds, increasing capillary permeability, activating your fibroblasts and causing arterial smooth muscle hypoplasia in the nails. And the reason why those platelets are able to access your digits is because, for instance, in lung disease, there are AV malformations which happen, which allow the platelets to effectively move from the right to the left side of circulation and then deposit in the digits. And that's where they cause all this fibroblastic activity and soft tissue proliferation. Also, tumor necrosis factor alpha has been implicated. Okay, what investigations should be done in somebody with clubbing? You want to do your full blood count and your chest x-ray, looking for evidence of lung disease and heart disease, ultrasound of the abdomen, looking at that liver, echocardiography, and others as per your clinical suspicion. So barium enema and follow through, all right, liver function tests and colonoscopy for inflammatory bowel disease. Remember, chest x-ray also for TB and fibrosis in our clinical setting. What is hypertrophic pulmonary osteoarthropathy? It refers to a triad. So there's three features we're looking for: clubbing, arthritis, and subperiosteal new bone formation. There is resultant swelling and tenderness at the lower ends of the forearms and legs. Clubbing is common but not invariable. You may have a situation with this HPOA and no clubbing. It may be primary or secondary to any cause of clubbing, and the commonest causes by far are bronchial carcinoma and pleural mesothelioma. Coming back to our case, right? So we had a middle-aged man coming with pyrexia, tachycardia. He has a right-sided consolidation with an effusion. He has an empyema and the ICD is placed. Which of the following treatments is recommended to improve resolution? The answer is C. Intrapleural installation of alteplase 10 milligrams plus DNase 5 milligrams twice daily for 3 days. So empyema, as we know, is one of the examples of suppurative lung disease that causes clubbing. That's what we said. And it refers to the presence of a grossly purulent pleural effusion. So management simply entails drainage of the infected pleural space, typically via placement of an intercostal chest drain. Some people call it a chest tube. Right? And a recent randomized placebo-controlled clinical trial demonstrates improved outcomes when we use both alteplase, which is otherwise called tissue plasminogen activator, and deoxyribonuclease twice daily for 3 days in the tube, beginning with the first day after tube placement. And this combination of alteplase and DNase demonstrated improved resolution of pleural fluid, shorter duration of hospital stay, and less need for surgical intervention in comparison with placebo or either therapy alone. Alrighty. As always, everybody, I just want to encourage you from the Word of God. Today we're speaking about humility. All right. The book of Luke chapter 14 verse 11, the Lord Jesus says, "He who exalts himself will be humbled, and he who humbles himself will be exalted." The book of 1 Peter chapter 5 verse 6 says, "Humble yourself under the mighty hand of God, that he may exalt you in due time." All right. God bless you, everybody. This is Ryan signing off. I hope you enjoyed this video. I'll catch you again with another informative video. God bless you.